Okay, ma'am. We are live now, ma'am. So, good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on Heart Disease in Pregnancy, organized by Pinnacle News Series. And today's episode is 14 in association with Ambala, Muzaffarpur, Godhra, and Hubli. It's my privilege to introduce the MOC of today's webinar, Dr. Madhumita Karthik. Ma'am. Ma'am is the consultant obstetrician and gynecologist and reproductive medicine in Salem, treasurer of Salem chapter of Tapisar. I welcome you, ma'am.
Thank you. Thank you so much, Sahiti. So it is my pleasure to invite one and all to the Pinnacle News Series, which includes societies from all corners of India. And it is organized by none other than Professor Dr. Sampath Kumari ma'am. We'll begin the webinar academic session with a prayer song. It is my privilege to introduce Professor Dr. Sampath Kumari ma'am, who is the professor and HOD of Sri Muthukumar Medical College Hospital and Research Institute. She was the vice president of FOXY. She is a Senate member of Tamil Nadu Dr. MGR Medical University and national corresponding editor of JOGI, founder secretary of Tamil Nadu Federation of Obstetrics and Gynecology, current president of OXY, retired deputy director of Institute of Obstetric and Gynecology, Madras Medical College, Chennai, president board of studies of Tamil Nadu Dr. MGR Medical University. Just a minute, I'm not able to see the screen.
Okay, Madhumita.
Ma'am is
Thank
also
you.
the past chairperson of FOXY Adolescent Health Committee, and she received the first ICOG Distinguished General Council Member Award, and she's the chairperson of Women's Wing of IMA South. And she's also received the IMA award. Yes.
Thank you, Madhumita. See, I welcome you all for this Pinnacle series. This is the series number 14, and we include societies from North, East, West, and South to have an unity. Today we have Ambala Society, Muzaffarpur Society, Godhra Society, and Hubli Society. I welcome Dr. Ruby and Dr. Aditya from Ambala, President and Secretary, Dr. Muzaffarpur, Dr. Vibha Nirma Verma, and Dr. Prachi, Dr. Hubli Society, Dr. Barakol under Dr. Udayasri, and Godhra Society President Dr. Raman Lal. I welcome our chief guest Dr. Hiramat. As soon as I told him that, sir, you should be the chief guest, immediately he accepted. Thank you, Hiramat, sir. Welcome. And we have two sessions. One session being the thrombosis prophylaxis in pregnancy. The talk by Dr. M. Vijayasri, chaired by Dr. Barakal and Dr. Vibha Verma. And we have the panel discussion. For this, we have Dr. Aditya Garg from Ambala Society to moderate the panel, and Dr. Kasturi Danamat being the expert. We have the wonderful panelists, Dr. Prachi, Dr. Radhika Gauri, Dr. Karpahambal, Dr. Sri Pritika, Dr. Saraswati, Dr. Udayasri, Dr. Husaina, and Dr. Shobna Priya. And welcome the MOCs, Dr. Madhumita and Dr. Radhika Gauri. I welcome you all for this webinar. And Prachi, you can put Sahiti, you can have the CV of Dr. Hiramat sir. I welcome the chief guest, Dr. Hiramat sir. Dr. Hiramat sir is the principal, KLEKHS JGMM Medical College, Hubli, former director of Karnataka Institute of Medical Science, Hubli, director H IVF Center, and past president of Hubli Dharwad OBGYN Society and Karnataka State OBGYN Association, chief patron and founder secretary of Karnataka State Obstetrics and Gynecology Association, ex-chairman of Breast Committee Foxy, past vice president of Foxy, past Senate member of Karnataka University, past president of Rotary Club of Vidyanagar, recipient of Millennium Fellow Award for Excellence in Academics by Foxy in 2000. So the Karnataka OBGYN Association is doing the wonderful work which was started by Dr. Hiramat. Dr. Hiramat, we are waiting for your blessing for the Hiramat sir.
Yes, good evening, madam. Respected Dr. Sampath Kumari, madam. And the guest of honors of today, Dr. Vibha, Dr. Ruby, and Dr. Trivedi, and all the presidents of the 4 societies and secretaries, and today's speakers and experts and panelists and panel members. First of all, let me thank Dr. Sampath Kumari, madam, who called me 3 days back. I was driving a car. I could not take her phone immediately. Then after some time, I again gave her a ring and she said, you have to be on this program. Madam, it is a great honor that you have invited me to this program. This is the first time I am joining to this Pinnacle news series. Looks to be a very good one because you are selected such wonderful topics and you have selected so many speakers all over the country. And I know Madam very well because we have fought an election together and Madam got elected. I was defeated by 7 votes. Then Madam told me, Hiramat, you try once again, you will be the vice president. I tried next time and I also became a vice president. That's how we know each other. And I have great respect for Sampath Kumari Madam because she is a great teacher. She is always loves to teach others and she is always active in academics in Foxy for the last 30 years. And there are 2 similarities between Dr. Sampath Kumari and me. She was as the founder secretary of Tamil Nadu Association and I am the founder secretary of Karnataka Association, which is 32 years old, madam. Yes, and today, excellent topics have been put up, particularly the thromboprophylaxis in pregnancy, which is very, very important topic because nowadays we are getting so many clinical cases where the thrombosis is occurring. Earlier, when 20 years, 30 years back, hardly we used to see 1 or 2 cases in a teaching medical college. But nowadays, even in the private nursing homes where the number of deliveries are less, still they are finding the thrombosis as one of the leading maternal morbidity mortality. I think this topic has been selected particularly keeping in mind this, I feel, Dr. Sampath Kumari Madam. And as you know that heart disease in pregnancy, and this is a really a very, very interesting topic. During my tenure as a professor in a medical college, I got this thesis done by 3 postgraduates. Oh. And every postgraduate, when they did a thesis, I could find a different thing. What was written in the first thesis is totally different in the second thesis. What was written in the third thesis is totally different because such a ever-changing subject, cardiology has grown so much so, and today we are able to see so many patients with severe cardiac disease becoming pregnant, carrying on pregnancy to term, ending with a healthy baby. I think a lot has been achieved in cardiology and we have great respect for cardiologists who have given us a lot of opportunity to treat the most difficult cases, particularly the congenital heart disease, where we used to advise, don't go for pregnancy, you will die during pregnancy and delivery. But nowadays, so many cardiac diseases which are congenital have been corrected and they have become pregnant, they have given deliveries, they have ended with nice babies. I think today the panelist will give definitely a lot of information With these few words, I once again thank Dr. Sampath Kumari Madam and whole team of Madam and the way they are doing now. This is a 14th series. I don't know what subjects were taken earlier, but today I'm lucky that I will be listening to these two important topics. I have cancelled all my programs. I will be attending these talks of all the experts, all the youngsters. I think that is how we have to encourage our younger generation. Thank you, Madam.
Thank you so much, sir. You forgot to tell the second similarity. Both of us were Senate member in
Okay.
our own
In the
states.
university.
Yes, sir. Thank you so much for your wishes, sir. Thank you, sir.
Madam. Thank you.
Thank you. Dr. Viba Madhumita, Dr. Viba is there. Dr. Viba, Dr. Ruby, Dr. Ramanlal.
Dr. Viva is traveling. Maybe she won't be able to connect. She's traveling.
Okay, Dr.
Yes, ma'am.
Ruby and Dr. Ramanlal is not there. We will
Mhm.
go with the scientific
Yes,
session.
ma'am. Yes, ma'am. I think we'll start the scientific session there.
Yes, we'll start with the scientific session.
Yes, ma'am.
Madhumita, can you introduce
Yes,
Dr. Vijayashree?
Yes, ma'am. So moving on to the first session, we have our so I think, can I see the slide? We have this a chairperson, Dr. Barakol, who's from Hubli Obstetric and Gynecological Society, and Dr. Vibha Verma, who's the president of Muzaffarpur Obstetric and Gynecological Society. And we have our esteemed speaker, Dr. Vijayashree.
Ma'am, I'm here.
Yes, yes, ma'am. So, ma'am is the
Introduce her.
professor and HOD, and she's also the she has numerous presentations, publications, and awards to her credit.
Yes, many
I think we
awards
can
and
go on
many
for this,
credits.
so many, plenty of awards.
Mhm.
And she's received national award for the DIRA program also, and she's received the Foxy Achievers Award, and from the president, and she's also received the India Pride Award also. Welcome, ma'am.
Yes, yes. Thank you so much, Madhu. Actually, can I share my screen?
Yes, ma'am.
Just
Sure.
guide me. I'm sharing my screen.
Yes, ma'am.
I just want you to guide me. Share. Shall I make this? Okay.
Yeah, please click
Can I
on
see my
share.
this thing?
Yes, we're able to see. Yes, ma'am. Yes, we're able to see
Yes,
us.
yes. I'm just opening my PPT.
Yes, ma'am.
Just give me a little time. Yeah, I'm done. Can you see the screen, ma'am?
Yes,
Yes,
ma'am.
go to the slideshow.
Sure.
Yes, yes. Okay, done.
Yes,
Done,
ma'am. Perfect.
done.
Yes.
And Sampath Kumari ma'am, thank you so much for giving me this opportunity. I'm so happy to meet you again. But unfortunately, my video is not working, but you can hear me throughout.
Yes, yes, definitely. Definitely. You can go ahead.
Madhu ma'am, thank you for the nice introduction. And I just want to introduce myself in a simplified way. I just done my UG and PG from Mahe Manipal Academy of Higher Education University. I am also FSCOG and ACME Medical Education also. I am a coordinator in our college and I get greetings from Kamam. Very good evening to each and everyone. I'll start off my topic without delay on thromboprophylaxis during pregnancy. When Sampath Kumari ma'am asked me to speak on this, I was just thinking how exactly I should start and end this program. So I thought I'll start with the risk factors and pathophysiology, as Hiramat sir was telling about increased incidence of thrombosis in pregnancy nowadays in the antenatal women. Next part will be the different case scenarios we did encounter in our clinical practice, at least once in our lifetime, each one of us. And lastly, I will go on and ending with the protocols and recent guidelines which are given for the thromboprophylaxis and anticoagulant therapy. So with this, I'll start off the topic. And to introduce, of course, the venous thromboembolism is a nightmare for all of us. Clots from the venous system then enter and they become deep vein thrombosis and at times pulmonary embolism, resulting in death of the mother, which is very unfortunate event. And it can happen as early as first trimester, and highest risk is in 1 to 2 weeks of postpartum. That is a noteworthy point. Postpartum period also we should not ignore. So the incidence would be in a lot of high-risk factors nowadays. 55% would be DVT. 16% of pulmonary embolism would be encountered in the high-risk cases. And throughout the globe, among the maternal mortality, 75% of them are because of pulmonary embolism. And we should not ignore deep vein thrombosis, because 25% of the deep vein thrombosis also can cause maternal morbidity and mortality. Coming to the global scenario, 19.6% of the women are dying because of embolism. Other than hypertension, infections, anemia, the remaining causes are less common compared to pulmonary embolism. So definitely this is a very much a risk factor throughout the globe. So what are these risk factors in the women? Of course, they're acquired. Nowadays, we are all sedentary lifestyle is going on. So many of us are obese. The age factor, because elderly age group and they're getting married little late. Then the surgery, the trauma, prolonged immobility, long air travels. Many of them are settled in US and all, and they can just come down, and then they can have a sudden onset of breathlessness and pulmonary embolism. Then coming to the additional risk factors, like because of the elderly age group, there could be ovarian stimulation, IVF protocols, especially the long protocols, the contraceptive pills which we give for delayed for pregnancy, and pregnancy itself is a high risk factor, postpartum period and hormone replacement therapy. All these are a risk factor for pulmonary embolism from puberty to menopause. So these are all very important, and we should not ignore the inherited causes of coagulation abnormalities, and the family history is equally important. So the pathophysiology in a nutshell, I don't want to go into the depth of that. We all know about it. Then immunomodulatory effects and hemodynamic changes in pregnancy, they all cause increase in coagulation factors. So hypercoagulable state of pregnancy and venous stasis, especially in the second and third trimesters, which can cause deep vein thrombosis and pulmonary embolism. So this, in a nutshell, I just want to tell there is activation of all the clotting factors, increased fibrinogen, factor 2, 5, 7, 8, and 10. And also the fibrinolysis are decreased. Then there is a decreased incidence of protein S, which might be rare, but there is a possibility. And increased resistance of protein C, all in turn cause increase in coagulation. And we are worried about deep vein thrombosis. So with this brief introduction, I would move on to the case scenarios which we would have encountered in our clinical practice one time or the other. So the first scenario is a 30-year-old woman, primary with 31 weeks of gestation, presents to the clinic with the left leg swelling and pain for the past 2 days, along with calf tenderness. She was diagnosed with gestational diabetes earlier, but unfortunately, she was well controlled by diet. There is no history of recent trauma or prolonged periods of inactivity. But when clinical examination, we found a swelling compared to the one left leg swelling is compared to right. The pain was there in the left calf, especially when walking or standing. There is tenderness of the calf muscle, and that is a Homan sign. Sudden dorsiflexion revealed excruciating pain in the calf muscles and the redness over the skin. All these are in favor of deep vein thrombosis. We all know that. And the risk factors in this particular case was the pregnancy itself, hypercoagulable state, and that itself can cause a blood clot. Gestation diabetes, though it was well managed, but there is still slightly increased risk of deep vein thrombosis. Venous stasis, because she is in the second trimester, around 31 weeks, there was compression of the pelvic veins and decreased blood flow in the legs. And of course, the nulliparity might be a slightly higher risk, though it is not very much significant. Then we want to diagnose it. Of course, we have done the D-dimer blood test, which is elevated. Duplex ultrasound, which is the gold standard for diagnosing DVT, was done. And it assesses the blood flow in the veins and identifies any clot. So venogram or MRI, there is a limited role. In this case, we could do only duplex ultrasound and it was sufficient. And venography and MRI also can be done if at all there is a suspicious DVT. So the treatment given in this case was anticoagulation, low molecular weight heparin or an unfracturated heparin, which can further prevent the clot formation and reduce pulmonary embolism. Compression therapy with a graduated compression stockings were given to reduce the swelling and pain. And of course, bed rest, when I'm going to the literature, there is controversy in this bed rest. There are two schools of thought. Prolonged bed rest should be avoided. At the same time, some activity restrictions should be done to prevent further clot formation. So that should be balanced according to the clinical scenario which we are encountering. Then monitoring, of course, is a close monitoring of the condition of the patient. Then the blood tests, especially the PT, APTT tests, and the ultrasound scans for the fetal well-being is very much essential to continue the pregnancy and deliver the lady. So that case went on well, and we didn't have much problem in the postnatal period also. The second scenario would be a 32-year-old woman, gravid to para 1, She presents for the first antenatal visit at 8 weeks of gestation. I'm sorry, it is gravida 4. She has a history of 2 early miscarriages and a prior diagnosis of factor V laden mutation, which is very, very rare, and it's a type of thrombophilia. We did see this case in our hospital. Her blood pressure and urine analysis were within normal limits. So we started with the counseling of pre-pregnancy itself. This counseling should start from the pre-pregnancy level, and we have to tell them very clearly about the which was tried in pregnancy. And whether they are educated and uneducated, we should make them sit and understand the venous stasis, which can be due to the gravid uterus, caval compression, the hormones and immobilization. All this will lead to increased coagulation. Then the coagulation factors itself are increased in pregnancy, and then decreased fibrinolytic activity, and of course the vascular damage because of the compression at delivery or an operative delivery. It's itself a cause for thromboembolism. This should be very much explained to the patient preconceptionally itself, because it's already known case of thrombophilia. So pregnancy naturally increases the risk of blood clots due to hormonal and physiological changes. We all know that. But in this thrombophilia, a genetic predisposition to clotting, it further elevates this risk. So this should be very clearly explained to them. And there are a lot of recent advances and studies are going on this thrombophilias, and yet a protocol should be formulated. Whatever we can do in that present scenario in our particular area, we could do that with a anticoagulant therapy. So the clinical presentation here would be recurrent pregnancy loss, especially late miscarriages and stillbirths. There will be preeclampsia, high blood pressure, and proteinuria. Abruption is also very common, premature separation of the placenta, and IUGR, fetus not growing at the expected rate, especially a fetus small for gestational age, less than 10th percentile is very, very significant in thrombophilias. So sometimes there will be life-threatening for the mother and the child, especially when there is abruption. They can be IUD and they can go into DIC also. And immediate delivery of the baby will be mandatory at times, especially when there is preeclampsia and related problems. So the complications would be venous thromboembolism, in turn pulmonary embolism. Thrombophilia testing is a must, and especially when the history of recurrent pregnancy loss, previous venous thromboembolism, and other pregnancy complications like preeclampsia. So you can see this chart. I think it is visible clearly. So here there are divided into high risk and all risk cases. If there is in pre-pregnancy therapeutic anticoagulation, any previous history of thromboembolism, if there is preeclampsia, if there is heart failure, sickle cell anemia, type 1 diabetes, and thrombophilia itself, whether it's a high risk or a low risk thrombophilia. Ovarian hyperstimulation syndrome, especially nowadays, is increasing IVF treatments, or any surgery in pregnancy or postpartum period, and simple severe hyperemesis or dehydration also can cause thromboembolism. All these are labeled as high risk. And in the antenatal period, we do have a risk scoring from 1 to 3. And we do see in the antenatal and postnatal period also. Antenatal period, the family history, age, parity, smoking, BMI especially, IVF treatment, multiple gestation, preeclampsia. These are all given each 1 mark, and especially postnatal period. If the operative delivery was there, prolonged labor was there, PPH, stillbirth, cesarean hysterectomy, where there is a little bit of immobilization compared to normal delivery, all these are also scored. And if any score, if it is 3, low molecular weight heparin should be started from 28 weeks onwards. If anything more than or equal to 4, as soon as the pregnancy is diagnosed or any abnormality is detected, we have to start the prophylaxis. Then coming to postnatal period, if the score is only 2 also, we should start low molecular weight heparin, and it should be continued until discharge. Minimum it is at least 6 weeks of follow-up is very much mandatory. If it is more than or equal to 3 score, then 7 days or longer if an ongoing risk is present, if it is not controlled. And the drug of choice will be enoxaparin, 40 milligram daily. Okay, if it is less than 100 kg lady, and if it is more than 100 kg, 80 milligram daily. We didn't find more than 170 kg lady, at least in our clinical scenario. And on the whole, it is 0.5 milligram per kg body weight of enoxaparin should be given. So this is the protocol which we can follow in the day-to-day practice. So here in this case also, we are given low molecular weight heparin to prevent the clots. And close monitoring was done with the regular checkups and monitoring of blood pressure, fetal growth, and other relevant parameters for fetal well-being. And everything went on well in this particular case. We were giving the subcutaneous injection of enoxaparin, and we monitored her. And there are other causes of DVT, which could be factor V laden. That's what we found in our case, but it is rare in our area. It is Caucasian descent and mostly seen in Holland in the global scenario. Factor V deficiency also has hypercoagulable disorder. Then protein C and S. There are anticoagulation proteins, and coagulation cascade is present. If it is deficient, then there will be increased clot formation. All of us know that. And antithrombin 3 deficiency also is equal responsibility, and if the deficiency of that will be having increased clot formation and at times stroke. So these are the things, other causes of deep vein thrombosis we have to keep in mind. Next comes the third case, 34-year-old female, which presents with history of recurrent miscarriages and DVT, previous DVT, and presence of lupus anticoagulant and high levels of anticardiolipin antibodies. She has come with these reports. CT scan of the leg was already done, and there was a blood clot in the deep veins. Patient was diagnosed with APLA and started on anticoagulation therapy with warfarin. Warfarin usually we give 2 milligram to 4 milligram. With vitamin K foods should be avoided. And that is what she was advised. So APLA means it's a presence of, as a obstetrician, we should know these things. So I thought just I'll add some of these criteria for APLA and the thromboprophylaxis. So presence of lupus anticoagulant, anticardiolipin antibodies. It is medium to high titer levels on 2 occasions, 8 weeks apart. A single test, we will not label her, but at least 2 occasions, 8 weeks apart, if it is positive, then we label them as APLA, especially when there is history of thrombosis and adverse pregnancy outcome. That could be 3 or more unexplained miscarriages before 10 weeks gestation, fetal death before 10 weeks of gestation, or a preterm birth less than 35 weeks due to severe preeclampsia or intrauterine growth restriction. If these things are there clinically and also investigation, we do label them as APLA. So we can see here the risk factors for APLA again is a genetic predisposition, the smoking, sedentary lifestyle and obesity, estrogen contraceptives especially, and prothrombotic disease. In this particular case, she already had a DVT previously and infections. So the moral of the story, at the end of the day, all these put together will have a venous thrombosis because of the increased coagulation factors and a clot. So this should be taken care into. So the clinical presentation would be thrombosis, of course, the blood clots in the veins, deep vein thrombosis, they can have a stroke or a heart attack if it is in the artery. Pregnancy complication like recurrent miscarriages, stillbirths or preterm births will be there. And skin rashes, especially with the low platelet count. They also can have renal and neurological symptoms. So APLA, IgG and IgM plays a very important role, and we need to repeat it 2 occasions, 8 weeks apart. So the diagnosis would be, obviously, it is presence of antiphospholipid antibodies. And this lupus anticoagulant is such a substance which prolongs the clotting time. So that also is very important. And other 2 components are anticardiolipin antibodies, which is a component of cell membranes, and anti-beta-2 glycoprotein 1 antibodies, which binds to the phospholipid. These are the 2 ones which we need to target to label them as APLA confidently. So the diagnosis would be, other than this investigation or laboratory diagnosis, we do have to do ultrasound at times, the CT scan or MRI. Maybe we should use to visualize blood clots or the affected organs. MRI is done in the antenatal period, but CT can be postponed up to postnatal period, especially postnatal thromboembolism will be more than the antenatal period. So diagnosis would be based on clinical presentation, lab findings, and imaging studies put together. We can make an APLA diagnosis. And of course, all of them should be taken care with aspirin, low-dose aspirin. Now, ASPIRE studies have been given up to 75, from 50 it has increased to 75. Now it is 100 milligram per day. And Medicare, of course, these creep bandages can little benefit for immobilization if there is a prolonged immobilization. So the treatment would be anticoagulants again, the warfarin, heparin, direct oral anticoagulants, that is the aspirin to prevent the blood loss. Other medications would be situation like corticosteroids if necessary, or immunoglobulins wherever it's indicated, can be given. So this would be the help of the endocrinologist. And the prognosis of APLAS varies depending on the severity and extent of the disease. This should be a noteworthy point. Usually, APLAS is a controversial thing for all the tablets or whatever we give. The prognosis is definitely fishy. So we have to explain to them about the severity and extent of the disease, especially associated with the preeclampsia and intrauterine growth restriction. So early diagnosis and appropriate treatment will improve the outcome. Next comes at another case, 32-year-old woman with a mechanical mitral valve who presents for prenatal care. She's currently on warfarin with a target INR of 2.5 to 3. But there are a lot of concerns in this woman. So a lot of cases will come, and we do have a panel discussion immediately next to my talk. So I won't go into the depth of these mitral valve, this thing. I'll just tell few things which are very important in relation to thromboprophylaxis. So counseling starts from pre-pregnancy. The risk of continuing warfarin during first trimester, warfarin amiropathy should be told to the patient, and switching to low molecular weight heparin. So what we can do is, we have to, as soon as she will be on some 2 milligram or 4 milligram of warfarin pre-pregnancy, as soon as we diagnose pregnancy, it will be shifted to low molecular weight heparin up to 12 weeks. From 13 weeks onwards, we can just shift over to warfarin because that is the most potent anticoagulant which we can give for any lady. Low molecular weight heparin also okay, it can be given, but prolonged use of heparin can cause osteoporosis and thrombocytopenia. That itself can cause bleeding again. And also there is no antidote for warfarin. That is the only problem. So we have to stop it by 36 weeks before she goes into labor. From 36 weeks onwards, we can restart low molecular weight heparin. And then because it is the short acting, intermediate and long acting, so many types of heparin are there. So we can just go on with that. And then even if there is any bleeding, we can go for a protamine sulfate, which is an antidote. And if it is warfarin, we have to keep fresh frozen plasma ready. Of course, coming to the antenatal period, ANCs and echocardiogram we should do. And the plan for delivery is important. Most of the time they deliver vaginally. But if there is a cesarean section and a general anesthesia, which will be carefully managed with anticoagulants, and spinal anesthesia will be avoided. And if at all to be given, it should be heparin dose should be avoided on the day of surgery. And complications like PPH for the mother and intracranial bleed for the neonate should be kept in mind. So the history, of course, we should know about the type of heart disease, severity and interventions. Anticoagulation therapy, whether it is warfarin, low molecular weight heparin, should be adjusted with the dosage, and INR should be around 2 to 3. And pregnancy progression will be monitored for preterm labor, preeclampsia and IUGR. And the management will be delivery plan, the mode of delivery, vaginal or cesarean section, and anticoagulation during labor and delivery should be given. And finally, not only after the delivery, there are rule of 5 is there, of course. So the cardiac condition in the postnatal period is very, very significant. They can have valve thrombosis, bleeding events, or heart failures in the postnatal period, which is very, very crucial. So it should be a multidisciplinary approach. The last case scenario, which is very dreaded, and all of us are really will have a nightmare if this type of cases come in the middle of the night, sudden onset of breathlessness, especially pleuritic and hemoptysis, and there is tachycardia and tachypnea for the patient. There are a lot of concerns in this woman. We all know that could be pulmonary embolism. And we have to remember a classical triad of chest pain, dyspnea, and hemoptysis, but unfortunately, it is only in less than 20% of the cases. However, the symptoms can vary from mild to severe or non-specific to life-threatening. So we should not ignore any type of sudden onset breathlessness. So immobility, especially prolonged rest, recent surgery, hypercoagulable state, again, whether it's inherited or acquired, pregnancy and postpartum, all this because of venous stasis and hormones would increase the risk of pulmonary embolism. Last but not the least, the endothelial injury can trigger clot formation. So clinical presentation, sudden onset dyspnea, chest pain especially worsens with breathing or retrosternal, cough, there will be hemoptysis. Other things like anxiety, dizziness, lightheadedness, sometimes syncopal attacks also can be there. So we have to check her pulse, tachycardia will be there, tachypnea. They can go into hypoxia and cyanosis because of the low oxygen carrying capacity and bluish discoloration of the skin. And we need to see about the right heart strain also. Palpable impulse, loud P2, S3 gallop, a systolic murmur louder on inspiration. All these are significant to diagnose pulmonary embolism. So not only whenever we say pulmonary embolism, the heart should be taken care of, not only along with the lungs. ECG will have sinus tachycardia. Chest X-ray will show pulmonary infarction, pleural effusion. CT angiogram is a gold standard and it will detect the clots in the pulmonary vessels. And echocardiogram, right ventricular dilatation and dysfunction will be seen. Other than this, we have to go for D-dimers, ventilation perfusion scan, and pulmonary angiogram, which is also a gold standard for pulmonary embolism. And you can see here the blanching because of the blanching of the vessels in the lung because of the clot. So these things also should be kept in mind. Here, 100% we need to give anticoagulation. Treatment involves unfractionated heparin, low molecular weight heparin, followed by warfarin or a direct oral anticoagulants also. Long term we have to give. And sometimes we need to go for thrombolysis with fibrinolytic agents whenever there is a clot to be dissolved. And surgical embolectomy has a role to remove the clot in a few cases. And 100% we have to give supportive care like oxygen therapy, fluid resuscitation, and management of other complications in particular disease. So now coming to the recommendations, this is the last part and very interesting and crucial part for all of us. These recommendations are given by the ACOG and ACCP. This is a very complicated table, but I'll make it in a nutshell. If there is so many clinical scenarios are there in our day-to-day practice. If there is a clinical scenario, prior single venous thromboembolism, and there is no risk factor at present, antenatally and postnatally, we can divide and we can just keep a watch on them. Antenatal period is less sensitive compared to postnatal period. Postnatal period is very, very vigilant. We have to be very vigilant and we need to go for surveillance or we have to start low molecular weight heparin. And any of the heparin you start in the postnatal period, it should be going on up to 6 weeks. And monitoring should be done with an INR and that should be targeted up to 2 to 3. And then when there are pregnancy with estrogen or long-term therapy already she is receiving and a prior venous thromboembolism is there, definitely you have to start prophylactic dose of low molecular weight heparin in the antenatal period itself and continue with intermediate in the postnatal period. Next comes if she is receiving already long-term warfarin, then we have to adjust the dose. Up to 75% of the therapeutic dose should be adjusted in the antenatal period. And we have to resume to long-term anticoagulation like pre-pregnancy in the postnatal period. Then if there are only high-risk thrombophilia and you can divide them into high-risk and low-risk thrombophilia. If it is high-risk thrombophilia is there, we can go prophylactic in the antenatal period and intermediate acting in the postnatal period. And if there is only low-risk thrombophilia, you can just wait and watch surveillance only, or you can do prophylactic or intermediate low molecular weight heparin in the postnatal period. At the end of the day, the guideline says postnatal period is more crucial compared to antenatal period. Antenatal period also we should be vigilant, but postnatal period which will be very crucial period for us, at least up to 6 weeks. Next comes the 2 or more prior DVTs are there. Then if there is any venous thromboembolism, whether it's DVT or mild pulmonary embolism, and she is not receiving any long-term therapy, then we can give only prophylactic in the antenatal period and go for intermediate in the postnatal period. If she is already receiving long-term anticoagulation, we have to adjust the dose and 75% of the therapeutic dose should be given in the antenatal period. And we have to resume to the pre-pregnancy anticoagulation in the postnatal period. And lastly, we are happy if there is no previous thromboembolism. And even if there is no previous thromboembolism, if there is a high-risk thrombophilia, we can start off with a prophylactic heparin in the antenatal period and move on with intermediate in the postnatal period. And if there is a positive family history or a factor V laden, then you can just do prophylactic and postnatal and antenatal period itself. You can go on with the same drug. And if there is a negative family history of thrombophilia, positive family history of venous thromboembolism and low risk thrombophilia and completely low risk thrombophilia, all of them equally, we can just have a surveillance in the antenatal period, and we have to give prophylactic heparin in the postnatal period. So if there is no family history, everything is negative, even if the positive family history with a low risk thrombophilia, completely low risk thrombophilia, we are little relaxing. We can relax, but still surveillance is important. Next comes to antiphospholipid antibodies. Whenever there is a history of venous thromboembolism, we have to give prophylactic anticoagulation in the antenatal period, and that will be continued in the postnatal period. And if there is no prior venous thromboembolism, you can give either heparin or a aspirin tablet. Here, oral aspirin 75 to 100 milligram, daily 1 tablet we can give. And then prophylactic heparin with the low dose aspirin for 6 weeks in the postnatal period to be continued, especially when there is recurrent pregnancy loss or stillbirth. So coming to the anticoagulants, this also one big list of anticoagulants are given, but usually we use enoxaparin or deltaparin in the day-to-day practice. If she is having less than 50 kg, usually we see less than 100 kgs or maximum up to 150 kg lady. And so if 80 milligram of enoxaparin, 40 if it is less than 100 kg lady, and up to 80 milligram per day if she is more than 100 kg, that will be enough. And deltaparin, of course, it is 2,500 units to 10,000 units we can continue. But again, there is a difference between therapeutic and prophylactic. So we will go on with this. Just in a nutshell, we can remember 40 milligram of enoxaparin, deltaparin 5,000 units 12th hourly we can give as a prophylactic dose. And it is 0.5 milligram per kg body weight. Enoxaparin can be given if you have to calculate targeted dose. So you can see here anticoagulation regime in a beautiful manner. The prophylactic would be enoxaparin 40 milligrams subcutaneously, deltaparin 5,000 units subcutaneously. This much is enough for our. This is the one which are giving in day-to-day practice. And therapeutic, when it comes, it is 1 milligram per kg every 12 hours. Enoxaparin, deltaparin 200 units per kg once daily. This is all related to prophylactic and therapeutic. But when it comes to unfractionated heparin, it can start from 5,000 to 10,000 units. It's very easy to remember. First trimester up to from 5,000 to 7,500. Second trimester from 7,500 to 10,000. Third trimester more than 10,000 onwards, we have to give unfractionated heparin. But we have to monitor with anticoagulant testing, PT, APTT, and INR should be adjusted up to 2 to 3. And antenatal period, vigilance should be monitoring. And postnatal period up to 6 weeks, we need to continue all these anticoagulations. Then, of course, postpartum coagulation should be continued. And surveillance with the antenatal period, the mother and the fetus also should be under close monitoring during this period of anticoagulation. So now coming to the last part, the recent advances. So now we know about the doses of anticoagulants and how exactly we are going to do different protocols. And of course, at the end of the day, our patient is in front of us, the clinical scenario, we know what we need to do. So accordingly, we have to adjust the dosage and give whatever type of anticoagulant we can choose. Coming to the recent advances, of course, there is something called personalized medicine. So they have to get a thrombophilia check, genetic testing for many of them, especially when they're recurrent pregnancy loss, stillbirths, IUGR, unexplained IUGR, all these things. But it's cost effective. It's better to go for genetic testing and clear this thrombophilia. So that is personalized medicine. Then coming to novel anticoagulants, we need to discover a anticoagulant which will cause less side effects and best therapeutic value. And there is definitely limited data on the safety during pregnancy. So that there is a lacune there. We have to go about with the novel anticoagulants. Then reversal agents, of course, in heparin, we do have protamine sulfate, but warfarin till date, we don't have anything. So we do use that fresh frozen plasma, and availability is a big query, and then cost also is very important. That also we should take into consideration. Then technology enabled monitoring. Nowadays, we have a lot of mobile apps for tracking anticoagulant use. Like we do everyday morning walk and we find the steps in our mobile phone. We do have these mobile apps, whether they're taking the dose or not. And these devices can be very easily monitored. and biomarkers also, easy detection of thrombosis can be done. But of course, everybody cannot use that. That is a big lacuna here, and very difficult to implement in integration into the existing system. Then comes the advances in imaging. Of course, the MRI and CT scan, we can take the help of them, especially that to find out the thrombus, angiogram and all we are doing from long time. So these are the recent advances which we can use. And but again, there is a limited, everywhere it's not available, and also it's cost effective. Then it's not cost effective, it's expensive actually. Then last but not the least, integrated care approaches. It should be a comprehensive approach and multidisciplinary team. We have to have a coordination between all the departments, and we have to take care of the patient in a holistic approach. Then at least we can save and decrease the morbidity, and we don't want any mortality due to pulmonary embolism, as sir was telling, Hiramat sir was telling initially. So there is so many cases increased nowadays. We do see almost every 2-3 months, one ICU case, we have this DVT and pulmonary embolism, even in our place. Most probably due to obesity, that is due to sedentary lifestyle or whatever, and elderly age group, especially IVF treatment. These are the common causes which we experienced in our clinical practice. And with this, I think I'm coming to the end of the talks. Thank you so much for patient hearing, sir and ma'am.
Fantastic, sir. Hiramat, sir, your
Yeah,
opinion.
thank you, madam. I was listening like an undergraduate to your
Yes,
talk.
sir.
Beautifully,
So thank you, sir.
so beautifully, she has covered all the aspects. Just chairing this session, I felt I should put some few words. Recognizing the condition is very, very important. Many
Yes, sir.
times, what happens is intern and PGs, they never look at the legs of the patient. They just see pulse and BP. And even though patient is there in the ward for 1 week, they never look at their calf muscle, legs. I think it is mandatory. We should make them to see the patient from head to toe. And
Yes,
early diagnosis is very, very important. If
yes,
you
sir.
delay in diagnosis, whatever the best facility you have, you are not going to save that patient. And
Yes.
minimum investigations must be done in every case. Though you may not be having all the big parameters, but minimum like the vascular investigations are very, very important. And nowadays, the cardiomyopathy cases have become so common that all these cardiomyopathy patients they are getting. Earlier, we never used to have an obstetric ICU. 10 years back, I established an obstetric ICU in our Karnataka Medical College. Then only we came to know how to manage these emergencies. Today, every hospital has got obstetric ICU, high dependency ward, and we are able to salvage many of the cases of the thrombosis. And a word about the changing from the injection to oral. See,
Yes, sir.
everybody should know that when to change from injection to oral, and once you change from the oral, when to stop the drug is very important. Many
Yes, sir.
times the patients are never told when they should stop the drug. And
Yes, sir.
lastly, as madam has told, that it is a multidisciplinary approach which can save the patient. And interventional radiology has helped a lot nowadays. We
Yes,
had
sir.
2 cases where interventional radiologist intervened and saved the patient. And vascular surgeons and cardiologists, they are a big asset now. I think with all these people with us as an obstetrician, we being the leaders, if you take the right time, their help, definitely we can salvage almost all the cases of these, because here there is nothing called as unexplained. Everything is explained. Only
Yes,
thing
sir.
is that a proper history is not taken. Patient is a known case which has been not considered, and you end up with a problem. I think madam has given a very good, a very elaborate the matter, elaborate the subject of the matter. Thank you, madam, for educating us so nicely.
Thank you so much, sir.
I thank Sampath Kumari, madam, for me to sit and listen. Thank you, madam.
Fantastic,
Ma'am,
sir.
thank you so much
Good.
for giving me this opportunity, Sampath ma'am.
Yes, as I told you, have taken a wonderful class.
Yeah.
Thank you.
Ma'am. Thank you.
Yes, now we will go to the second session. Radhika Gauri, can you introduce the moderator and the panelist?
Yes, ma'am. Thank you, ma'am.
Moderator is held up with the, yes, two
Yes, ma'am.
lines you can tell.
Okay. So we invite and welcome Dr. Kasturi ma'am, who is the president of Karnataka State OB Society from 2022 to 23, and she's also professor in HOD, Department of OBG, KIMS Hubli. And she's held many positions, important positions in the Hubli Dharwad OBG Society. And she has been faculty at the national international conferences, and she's conducted many workshops, contributed to chapters. Welcome, Dr. Kasturi, ma'am. And next we invite Dr. Aditya Garg, sir, who is has done his MBBS from Rotak and MRCOG from London, and he's done his CCST in UK. And he's a consultant in fetal-maternal medicine and gynecology. So he's at present, he's from the Ambala OG Society, Haryana's first PNDT approved center with genetic tests. He has his own ultrasound center, and he's an ex-consultant at fetal-maternal medicine, Brighton and Sussex hospitals in the UK. And he's also worked as senior registrar at St. Mary's Hospital, Manchester. It's quite famous big hospital. And he's also a lecturer in OB-GYN at Manchester University. Senior lecturer for communication skills training at Salford University. And also he has special interest in hysteroscopic surgery and red cell isoimmunized pregnancies needing fetal transfusion. He has got multiple paper and poster presentations in international conferences, including RCOG, FIGO, FMS, ASCOG, and COGI in Paris. And he's contributed to 14 articles in journals, including the three first author articles in BJOG and AJOG. And we invite Dr. Prachi Singh, Secretary, Muzaffarpur OB-GYN Society, who is our panel member, and myself, and then Dr. Karpagambal Sairam, who has special interest in fertility, high-risk obs and gynae, and also gynae endoscopy. She's won award ACOG, RCOG Traveling Fellowship in Gynae Endoscopy in 2017, and also ISAR award. She's won, and also executive committee member of OXY in Chennai, and peer reviewer of indexed journals. And she's presented papers and posters in various national and international conferences. And she's a consultant at Sri Sai Clinic. And next, we invite Dr. Sri Preetika, who is a senior assistant professor and department academic coordinator in Chengalpet Medical College Hospital, who has done her MSOG in Kilpark Medical College, and her experience, she has 9 years of teaching experience, and is an NMC nodal officer, faculty and speaker at state and national conferences, and also a Manyata workshop coordinator. Next panel member is our Dr. K. Shobana Priya, who's an associate professor from Bharat Medical College and Hospital, the member Clinical Research Committee, FOXY 2022 to 25, and she's a founder member of Kanjipuram OG Society, immediate past joint secretary from IMA Tamaram, and Best Service Provider Award has been given to her for PPI UCD insertion in Chengalpet, and also she's won many other awards. Her interest is in high-risk obstetrics and gynae endoscopy. And then we have Dr. Sheikh Syed Husaina, who has done her MBBS at Savita Medical College Hospital and MS in 2017 to 20 at Sri Balaji Medical College Hospital. She has got 4 papers published, and she has done her MRCOG, and she has an experience of 4 years in obs and gynae. At present, she works as an assistant professor in Sri Muthukumaran Medical College Hospital and Research Institute. She is a senior resident at SRM Medical College Hospital and Research Center. Dr. Uday Shri Urkara has done her MBBS at DGO, DPNB, and fellowship in laparoscopic surgery. And she's an associate professor, Department of OBG from Hubli JGMM Medical College. And she has affiliations to FOXY secretary. She's worked as secretary in FOXY, in IMA, and also in Dharwad. And she's won many awards, Kuppusamy Mudaliar Rolling Trophy, Young Speaker Award, and won the Young Talent Award at UA FOXY in Madurai, and runners up at national level ICOG quiz competition. So welcome, Dr. Udayashree. And we have Dr. Saraswati, who has special interest in fetal medicine. She's an assistant professor, Department of OBG from Hubli. And she has the affiliations to FOXY, FPAA, IMA, and EASE. member of Hubli Dharwad OG Society, and she belongs to Hubli, Karnataka. And thank you.
I think Dr. Aditya has held up with some case, I think.
Okay,
So, Sahiti, can you present that presentation in the group? Can you share the presentation,
Yes,
Sahiti?
ma'am. Yes, ma'am. Just a second.
And Udayashree is in the attendees group, I think. Udayashree and Baralal.
Oh,
You can change them. So I think I welcome Dr. Shobana, Dr. Sri Pritika, Dr. Karpahambal, Dr. Radhika, and Prachi and Dr. Udayashree. So we will have a discussion with the panel which he has posted since he is not there.
Okay, madam.
Yes, ma'am.
We'll have a good
thank you,
discussion.
ma'am.
Yes, ma'am.
Mm. Sahiti, are you sharing it? Hope all the
Yes,
panelists
ma'am.
would
Yes,
have
ma'am.
gone
Yes,
through the
Please give me a
presentation.
second, ma'am.
Yes, madam.
Yes. Next slide, Sahiti. So we will go with the first case. Para 1 with previous LSCS, 38 years old. Before starting the case, I will introduce. Now I am in US to see my grandson. I didn't see the PPT. Just now I am seeing. So all of you should have a good discussion with this case.
Okay.
Para 1 with the previous LSCS, 38 years old. PET in last pregnancy with birth weight of 2 kg. Her weight is 86 kg and 80 kg on booking. Booked at local GH with poor compliance of visits. Attends at 28 weeks with the routine antenatal care. She wants your advice for a GTT with a fasting blood sugar of 134 and 2 hours blood sugar 180. So she is having PET and diabetes also. You note that she is a short-statured 5 feet and BMI is 37. On further history taking, she tells you that post her last LSCS, after her last LSCS, she developed a swelling of the left leg which was painful. The doctor at that time told her to be on some injections which she stopped after 2 months as she was okay. And she was told to wear elastic stockings which she could not tolerate due to hot weather. Now we'll start with Dr. Karpahambal. What do you infer from this case?
This lady actually falls under the very high risk category for DVT because on thromboembolism, because the first factor is definitely BMI. That's one major risk factor. Number two, previous history is very, very significant for her. Apart from that, now her diabetes, she has become diabetic now. And this is definitely, she comes under very high risk category. And by all practical purposes, because she has been on irregular antenatal care, she must have been evaluated for APLA also because of the birth weight was low, FGR, even if the baby has been delivered, I mean, even after 34 weeks. So all these criteria put together, definitely we have to evaluate her and start her on thromboprophylaxis as early as possible, apart from taking care of her diabetes and her other risk factors for FGR monitoring.
Okay. Dr. Sri Pritika, this patient is coming to Chengalpatta. How are you going to proceed with this case? Now I think she is 20 weeks, no?
28, ma'am.
28.
She comes to 28 weeks with routine antenatal care.
Routine antenatal care.
Yes,
How are you
ma'am.
going to proceed, Sri Pritika?
Yes, ma'am. As Madam told, she already had, she's obese, she's having diabetes, and she
Next
already
slide,
had
Sakiti.
preeclampsia. So now also she's more prone for preeclampsia, and in this pregnancy also she can go in for thromboembolism. Like we have to rule out other thrombophilias which are inherited, and you should also rule out Apgar syndrome, which Madam was discussing because she already had one birth weight of 2 kg. So we should also rule out that. And in this pregnancy, you should do risk stratification, and you should put her on other drugs, like empirically you put her on aspirin, you give her all the other supplements, and we give her proper antepartum fecal surveillance. She may require frequent ultrasound monitoring, and Doppler monitoring may also be required as a part of routine pregnancy care. And other than that, we should routinely give her this enoxaparin of 40 mg daily.
So what will you start in Chengalpattu? Next slide, Sakiti. Do you have enoxaparin or low molecular weight heparin?
Yes, ma'am, we have enoxaparin. We do give enoxaparin 40 mg subcutaneously daily.
So you are going to state. Dr. Shobana, when are you going to deliver her?
If she is having a normal antenatal, like the lighter is good and her antenatal surveillance is good, I will not let her post-dated, madam. That is one thing. And if unless there is an obstetric indication, I'm not going to plan for cesarean. So I have for a spontaneous labor, and of course at that term,
section.
I will consider that our antenatal profile again, how is her, and whether if she doesn't have any deep vein thrombosis or any, if she's fine with this thromboprophylaxis and other thing, I will allow her for normal delivery, ma'am.
Very good.
And the
So
thing is,
this
I will
risk,
not allow her for post.
so the risk
At
factors are
40,
for theory. Radhika, Shobana wants to go for a normal delivery. If the patient comes to Tirunelveli, your
Yes,
ESI
ma'am.
hospital, will you go for a normal delivery?
No,
Next
ma'am.
slide, Sahiti.
Okay.
Yes, Radhika.
Yes, ma'am. In our setup, we will do a elective repeat cesarean section at 37 to 38 weeks after giving her steroids. And we will have to give the heparin dose. First of all, we have to refer her to the anesthetist, and based on the risk factors, even at an earlier period, 32 to 34 weeks, we will get the assessment because she BMI is high and she is on this fragment, low molecular weight heparin. So we will get an anesthetic assessment and fix the date. And also we will take a rheumatologist or a hematologist opinion as well in this. So it is a multidisciplinary management. Anyway, regarding the delivery, we will do a elective repeat cesarean section. Give the previous night, we will have to give the dose, and then the next day, the dose has to be omitted and do the section. And at the evening, night, we will do the cesarean for this case.
Okay, nice. Dr. Prachi, do you want to differ from anything?
Ma'am, she is left because she has some emergency case, it seems. At cesarean section.
Oh, Prachi has left.
Prachi has left, ma'am.
So,
She wants
okay. Any other
excuse for-
panelist is there?
Ma'am, this is actually previous LSCS, ma'am.
Previous
So I
LSCS.
think we'll have to go for an elective cesarean
Elective
section.
section.
And
Yes.
in this, we'll have to ensure that she's not having immobilization. You should advise her early ambulation.
Postpartum, yes.
See,
Yes.
few things we
sorry,
just
ma'am, I missed the previous LSCS. That was my mistake. Sorry, ma'am.
that is
Shobana,
what I will tell you.
Shobana, that is the reason I'm asking everyone. I thought you have missed that previous LSCS.
The
Because
thing-
in our
Yes, ma'am.
situation, yes, Karpahambal.
So the first thing that we need to understand here is, madam, there are two components. One is the preeclampsia component, growth restriction component, which is a vascular entity. The other is a GDM component, which can have a high birth, increase the birth weight.
Yes.
But in practical scenarios, what we see is the vascular component always takes the lead, madam, upper lead. So that is the
Yes.
reason why many people, even if they are GDM on insulin, but they have a preeclampsia component, vascular entity, placental vasculature is defected, the blood supply is affected, they also develop a growth restriction component. So another, the main thing here is, I do understand that if she wants to give a VBAC also, it is fine, but induction at whenever the baby is having a normal Dopplers, before it actually the Doppler worsens, the pediatricians are very happy when you give a baby which is intrauterine with good Doppler, rather than create trouble intrauterine and create more trouble in MICU. So best is to have the idea where when those babies, definitely they create trouble by around 36 weeks, madam. Definitely the mother would have developed preeclampsia by then, or the baby would have abnormal Doppler. So we will be forced to repeat.
So since we don't have the moderator, we will take it that we will go for an LSCS without any complications. Okay, because with all the risk, as Radhika was telling, we have to stop the heparin earlier and we have to restart it as early as possible. We have one case, they forgot to restart the heparin, and finally we lost the patient. So always we have to restart it. Then you can continue for at least 6 weeks and then you decide with the cardiologist team. Dr. Aditya, I don't know what he did with this case. What precautions do you take post-delivery? That everything you have discussed, I think. Next, Sahiti. How long will you prescribe this low molecular weight heparin? Shobana? Shobana ஏற்கனவே தியேட்டர் ட்ரெஸ்ல இருந்தா. She has also left, I think. Shobana, how long will you prescribe this low molecular weight heparin?
She has a high risk factor, ma'am. So I would
Yes.
like to continue for 6 weeks in the postpartum period, ma'am. Along with early ambulation and improving the hydration as well, ma'am.
Then you leave to cardiologist for his choice. After 6 weeks, it is cardiologist patient. Okay, hope all of you agree with the same thing. Yes, next slide, Sagiti. We will go with the case
What
2.
else?
Yes, anything, Shobana?
No, ma'am, rheumatologist, I said. Usually
Okay,
this DVT vascular surgeon or rheumatologist.
Yes.
Yes. Thank you.
Now we will go with the second.
Yes,
Why
ma'am.
rheumatologist? What is the point of going to rheumatologist?
No, the DVTP, they will usually they give the they are the ones who give the fragment. Hematologist also, either of them, whoever is available, we have to usually involve them. Cardiologist only, I think the cardiac cases.
No, you can forget the cardiologist. Why rheumatologist? I am asking.
Because they will investigate for APLA and other underlying factors which we might have missed in the previous pregnancies.
Yes, Radhika. I thought your husband is rheumatologist. You are advising rheumatologist.
No.
Okay.
No,
Okay.
usually in UK we usually refer to hematologist or usually hematologist, but if we don't have them, then the rheumatologist will.
Yes, the Sri Pritika, whom you will refer in your place, Chengalpet.
Ma'am, we are also referring to hematologist only, ma'am. One
Since
case
we
who
don't have
had a
rheumatologist,
thrombus,
hematologist is okay. If no
Okay.
cardiologist.
and one case we needed intervention, we refer to a vascular surgeon, ma'am.
Yes, vascular surgeon and hematologist. Since
Hematologist.
Radhika was telling, I was asking, but her point is also taken. APLA.
Correct.
Ruling
Yes.
out. Okay, now we'll go with the second case. 28-year-old paraman with a previous normal delivery at our center. Booked patient with no antenatal concerns, came with a history of 2 to 3 days for being short of breath at 34 weeks. CTG was normal, tachycardia and tachypnea was noted. Patient given antibiotics for 2 to 3 days and asked to follow up if not better. Reported in 3 days with shortness of breath following even mild exercise. Persistent tachycardia prompted a cardiology referral. Echo showed left ventricular ejection fraction of 35% with normal heart. Next slide. This was referred to local regional center as patient was stable and not in impending delivery or heart failure. Now we will go with the discussion of this case. Again, we'll start with Karpahambal.
So this is a very typical scenario, madam, where the peripartum cardiomyopathy is the most there's a diagnosis of exclusion, but what happens is whenever we do an ejection, whenever patient comes with tachycardia, tachypnea at term, especially in the last month or last trimester, and which they can present even in the first 6 months of delivery. So it is a type of dilated cardiomyopathy. The most important thing here is diagnosis. Echo is the most important thing because her ejection fraction is only 35%. At least she does not even have enough pumping capacity to pump for her own well-being, for her own circulation. So now the question comes for the baby. So definitely delivery will be the most important thing, and the delivery should be done in a tertiary care center. And the cardiologists also measure what is called as fractional shortening of the left ventricle. So that is also can be criteria for diagnosing cardiomyopathy. So this patient, because of the high risk, there is high risk of clotting. She needs an ICU setup care, high risk of pulmonary edema and pulmonary embolism. So we call 4 P's: pulmonary edema, peripartum cardiomyopathy, pulmonary embolism, and these people sometimes, because of the thing, they can develop. They will be on sometime on anticoagulation. PPH is also a risk factor for them.
Okay, so the definition on PPM and all, it is a known factor. Next slide. So, Shobana, how are you going to deliver this patient?
Ma'am, Dr. Prachi is also back, she said.
Dr. Prachi?
Yes, madam.
How are you going to deliver this patient? She is a case of postpartum cardiomyopathy and now 32 weeks. And how are you going to proceed and how are you going to deliver this patient? On echo, the left ventricular ejection fraction was 35%.
I don't think she needs delivery just now because she's only 32 weeks. So
Yes.
we'll manage her problem, which is the cardiac condition, and the symptomatic treatment will be given. Along with that, bromocriptine has been found to be effective in cases of cardiomyopathy in this scenario. So that
Yes.
can be given.
Okay. Nowadays, the bromocriptine is also yes, Prachi.
So, so first
Shobna, yes, tell.
admitted
Next slide, Sagiti. Shobna.
admitted in HTU and stabilize the condition and give her oxygen, and then if there is some heart failure after the consultant cardiologist opinion, we will start on with if she is in failure, and we have to be starting her with the anti-failure management. Look for the sign, look for the improvement, and depending upon her stability, if she improves, we can try to if she improves, probably a week or so, we can try to continue and then terminate the pregnancy as early as possible, because for us, the mother is the priority. And if she deteriorates, probably we cannot continue further as well. No?
So, how will you deliver? Normally or LSES? You want to decide to terminate?
With an high-risk team, I would like to terminate preferably by cesarean section.
Yes.
With the entire team at the back, cardiologist and intensivist, and with the entire back, giving the prognosis, because the prognosis is very poor, so it is better to have a team and terminate by cesarean section.
Will you explain about the mortality to the attenders?
Obviously,
yes,
yes.
Yes.
Mortality of up to 50 to 80%. If the patient is in failure, about 80%. So definitely there has to be explained to the patient attender about the prognosis. Then we would like to terminate, and we cannot wait till, since it is 32 weeks, we can't wait for the baby's maturity, leaving the mother to deteriorate further.
Sri Pritika, what's your opinion?
Yes, ma'am. This case requires a multidisciplinary approach. So not only the obstetrician, we have to discuss with the cardiologist and also with the anesthetist. Then we have to plan a delivery. Though guidelines says that vaginal delivery can be allowed for a hemodynamically stable patient who is in PPCM. Without taking risk, as Shobna said, we have so many cases, ma'am, and recent past we have managed so many cases of PPCM in our institution. And in all these cases, we have done an elective cesarean section in the day house with all the experts being available, and proper monitoring was done. And post delivery, apart from bromocriptine, nowadays cardiologists are advising to use enalapril, ma'am. Like ACE inhibitors and ARBs have a very good role in recovery of PPCM, though it is not advised during the pregnancy period. Like if in 32 weeks, we are not giving enalapril before we deliver the baby. But after delivery of the baby, enalapril has proven to have a good effect. So importantly, in this case, like all the things, we have to go for drug management. So important, we give bromocriptine, and we give other oral anti-failure drugs, and we give anticoagulants if needed when there is a very slow heart rate. To prevent thrombus, we also give heparin prophylactically. And for afterflow reduction, we give vasodilators. And as usual, for preload reduction, we give diuretics, and we manage the case accordingly. And till 42 days, we have kept the patient, as we are in a government setup. Till 42 days, we keep them in hospital, and we discharge them safely, ma'am. And we have delivered around 10 cases, and we have sent them home safely, ma'am.
Okay, 10 cases of antenatal patients. Normally, we diagnose it after delivery.
Yes, ma'am. Actually, we
Most
had
of
3
the
cases antenatally, 3 cases
When do you-
antenatally, and 7 cases from the after postnatally from the wards. They were shifted with breathlessness, and they were diagnosed as PPCM.
Among the 10, what was the mortality, Sri Pritika?
Ma'am, we have lost only 1, ma'am. All other
Only
9
one.
we.
Okay,
Yes.
nice.
Ma'am,
Radhika,
usually-
in your
Yes,
USA,
ma'am.
you diagnose PPCM before delivery, during antenatal, or after delivery?
2 cases we had, ma'am, but one was 20, I think around 34 weeks. She had a strong family history. Her mom also died after delivery. Mother died. She didn't know the exact cause. She said immediately after delivery, postpartum, she died. So, and then we closely followed her, and then she had a reduction in the EF, but not up to 45. It was 50. And she had breathlessness, came with tachycardia. So we referred to the TBMCH Medical College. and she started on all the anti-failure measures.
Sahiti, next slide.
Yes, ma'am. The other patient was diagnosed post 40-year-old para 3 month, typical description, and then she had after third LSCS, she had dyspnea and she also had palpitation and edema, and then she was immediately referred and she was kept in ICU. After 2-3 weeks, she recovered. Both are alive and fine.
And importantly, we have to stress. Ma'am, importantly, we have to stress them and contraceptive counseling, ma'am. We had one case which we delivered around 6 months back. She had an EF of only 30%. We safely discharged her on 42nd postnatal day, means post-operative day. And with the property, we discharged her. I don't know where she removed it. Now today she came to the OPD with 16 weeks of pregnancy, ma'am. Because her baby died at 3 months, it seems, ma'am, because of some infection. She lost her baby. She has removed her property. Now she came again with 16 weeks of pregnancy. So it's important that we stress on the contraceptive counseling also.
So Sri Pritika should be ready for the audit for this pregnancy, maternal audit.
Not be handled by me, ma'am. It's from our institution.
So that is the reason for heart disease patient, we should not discharge. At least, as she was telling, 42 days to be kept. Once they start going home, they will start working and they will come with the PPCM.
Yes, ma'am.
So the next slide. Kasturi madam is not there, I think. So the PPCM, previously we thought that if this is a PPCM, it will end up only in the maternity, but with a good multidisciplinary care, now the patients are alive and they come with the next pregnancy. So which contraception you decide to be the best contraceptive method, Radhika? She was telling, no, Kapati was given and the Kapati she has removed or it fell by itself. So which could be the best contraceptive in such a type of patients?
Non-dependent, I mean, it should not be dependent on the patient. So Kapati is usually the best, ma'am. Apart from that, Mirena coil is also another good one.
Both same only, no. If they want to remove means they will remove. Karpagambal, do you think of any other contraceptive methods?
No, madam. See, we actually prefer to avoid hormone-related contraceptive pills.
Yeah, Depo also has thrombosis risk, so we cannot give that.
So best is to
so nobody want to tell vasectomy.
Vasectomy is very good.
I am one strong favorite of vasectomy, madam.
Yes,
the only reason here about this PPCM is this counseling the patient about the recurrence risk in the subsequent pregnancy can be a bit earlier also and more drastic also.
Ma'am, one more request. Yes, ma'am, if you become Foxy president, you should tell ma'am, both of them should be, when they sterilize, they always say tubal ligation only. But we should
that we will do in 28. Now we will talk with the 25.
Okay.
So that vasectomy counseling is important.
Yes, ma'am. Absolutely.
Uptake about from our patients, I mean, our community side is not very good.
Very poor.
Yes.
Udayashree ma'am also joined, ma'am.
Okay.
Who has joined?
Udayashree
Udayashree was yes, Udayashree, in your place, Hubli, what will you do?
Yes.
This patient comes with the PPCM. What is the type of contraception you will counsel?
Madam, permanent method is ideal, but as you said, vasectomy acceptability is very, very low, madam.
Very, very low. So that's the reason. So
the easy reason which the in-laws and the husband will tell is when her health is deteriorated, how can my son get a vasectomy? What if she's no more? Like they all have such ideas.
Otherwise also, if alive also, they will have some different ideas. That's different.
In this case, they have a strong reason, madam.
Yes. So as all of you decided, the Kapati is the best contraception. Since they will not be accepting this hormonal, as we told, this Antara, nothing is possible for this case of PPCM. We'll go with the third case.
Okay.
Sahiti, yes. This is GP referred a case of 10 years ago. And when I was fresh into the private practice, Aditya was fresh. Okay. Following recent elections, our local MLA was made the health minister and IMA was felicitating him in a meeting. So during this case, I think, a 25-year-old primee was referred in labor at 3 centimeters with a moderate contraction as her doctor was not in town. Patient was a case of rheumatic heart disease with mitral valve stenosis and had balloon valvotomy. She was being treated in CHC and was in touch with her CTVS surgeon, who, as per patient, and has reassured her. Before going to the next slide, we will see when will you do the balloon valvotomy in an antenatal patient. We'll have the discussion and we'll go to the next slide. Karpagambal, we'll start with you.
So ideal, it all depends on the mitral valve orifice opening, madam. If the orifice is very close, less than 1.5 centimeter, and the patient is actually not having NYHA criteria, class 1, very stable patient hemodynamically, then second trimester is an actually good time to do an balloon valvotomy, madam.
So this patient, I think they would have
Aditya
done.
sir has joined now.
Aditya
Ideally,
sir has
preconceptual
joined.
counseling should be given, ma'am. Ideally, preconceptual counseling should be given, and it should be planned prior to the pregnancy, if possible, if they come to us. Ideally,
We will ask
if they come
Aditya to
before.
continue. Dr. Aditya, have you joined?
Yes, ma'am. Ma'am, sorry, I'm joining from my phone. I've just come out of OT, ma'am. Really sorry.
No problem. 2 cases I have discussed. You
I know,
discuss
ma'am.
this
I know.
third
Thank
case.
you so much.
Third case you can discuss, Aditya.
Right. So yeah, ma'am, basically the CTVS surgeon had assured the patient, and the patient was being followed up by a general practitioner in our area, a BMS doctor. So the patient was not even in touch with any kind of a gynecologist or cardiologist locally. So that's it.
So next,
Sahiti,
next slide.
Next slide. Yeah. So, ma'am, in the middle of night at about 2 o'clock, I ended up doing a cesarean for her because I had no clue what her echo was like. All I knew was that she had a heart defect and some valve, and she was clinically stable. The only anesthetist I could find at that time was an army officer who was related to my dad. And he kind of came pro bono at 2 o'clock in the morning. Bless him. So this patient had an uneventful cesarean section, discharged after 3 days, and that was my memorable night. Then she turned up again. Sorry,
Aditya, only one question. For this heart patient, will you discharge by 3rd day?
Ma'am, ideally not, but at that time I had no knowledge of what the heart defect was like.
Okay,
I did speak to her. I did speak to her CTVS surgeon, who was the same surgeon who actually did a bypass on my dad as well, and that's how I had his number. So yeah, he said that this patient had a mild mitral stenosis and slightly dysplastic mitral valve. So he had done a balloon valvotomy prior to this patient becoming pregnant.
Okay.
So
now it is not done in second trimester prior to pregnancy.
No. This was an antenatal patient, ma'am. Yeah, this was done prior to pregnancy. So then this patient again turns up 4 years later at 8 weeks of pregnancy. This time I obviously contacted the CTVS surgeon, and he explicitly told me that he had warned the patient against getting pregnant. But the patient then wanted to continue with her pregnancy because there's a tendency in North India of having a kind of male child compared to a female child and all that. And the first born was a girl. So then I referred her to a local cardiologist who then did a echo and told me that it is not that bad. So we can kind of continue. Her gradients were reasonable, ma'am. They were not so bad that we kind of offered her a termination and all that. So her mitral valve area was, if I remember correctly, around 1.8, 1.7, which falls under a very mild category. So the cardiologist's advice was just continue with the antenatal care and follow up. So then I started following her every 2 to 4 weeks. And I sent her to a cardiologist every 4 weeks because I was more worried about her than her actual cardiologist or the surgeon. And in the end, an uneventful cesarean was done. But I got her admitted in a post-op cardiac ICU in a local corporate hospital. And after that, an unremarkable post-op recovery was made. After her recovery, the patient's husband came to me and said, Dr. Saab, the cardiologist actually did not even visit us once in the ICU. So the whole matter was managed by resident doctors and me. So
Aditya, one question. Why didn't you do LSCS with sterilization?
I was about to ask.
Ma'am, the patient explicitly told me that unless you can tell me it's a boy, I will not agree.
Okay, Sri Pritika, what will you do in our place?
Definitely an elective cesarean section with sterilization. Prior to the delivery, we will have to counsel them that it is more life-threatening for the mother. So rather than having a male baby, it is better she has to be alive. So we insist and we do sterilization, ma'am.
Yes, that is the best thing. I have lost that. Aditya, can you tell? I think Sahiti
Yeah,
was.
don't worry, ma'am. I'll take it up on my laptop and I'll. Can I put it on the phone as well, ma'am?
Yeah.
Okay.
Yes.
So,
Sahiti, it's
Ma'am,
So
can
we
you see
can-
the screen, ma'am?
slideshow mode.
Okay, 1 second, ma'am.
போட்டது எங்கே போயிடுச்சு. So Karpahambal, what will you do in this case?
See, this case has been actually, she has been absolutely asymptomatic. She was in NYHA class 1, so everything went on well smoothly. But not all cases are like this, madam. So that is,
ma'am, she was actually class 2 in her second cesarean.
second cesarean came class 2.
Her disease had worsened. That is why the cardiac surgeon had actually warned her not to get pregnant.
See, the problem here is, the cardiac lesions will progress as time passes by. So that is the reason why, very important for us to counsel them about how the next pregnancy can be more riskier than the previous one. But our women, they just don't listen. They just want to have,
They don't want to hear bad things.
Yes.
I have had a patient who had a mitral, actually valvotomy done, balloon valvotomy. She actually developed severe supraventricular tachycardia, and she had to undergo radiofrequency ablation. And she actually landed up in atrial fibrillation during pregnancy, recurrent fibrillation. Heart rate would be like 120, 130 all the time. And actually, as pregnancy progressed, was around 160, 180. And we had to manage her in the hospital. And she was given, even though we know that beta blockers have a risk of growth restriction oligohydramnias, but these low doses, we gave her bisoprolol, Concor. So we gave her 2.5 milligram twice to control her heart rate, to control her, she was on digoxin 5 days out of 7 days a week. And she was on low dose diuretics because we were worried about so the baby, after 28, 30 weeks, whatever it is, we thought we'll just salvage the baby. And in spite of the recurrent atrial fibrillation, we could give her a healthy child, and baby went on till 32 weeks. And we did an elective cesarean section. Post-operatively also, she was on follow-up. And the most important thing is, she was on anticoagulation. She was on therapeutic dose of anticoagulation. Actually, she was on low molecular weight heparin, 60 milligram twice a day.
High dose.
Very high dose.
Okay. Then Aditya, suppose this patient, again the second LSCS girl baby, then will the patient will not accept for sterilization even for third? I'm asking in your place.
Ma'am, see, the problem is you so much want to play God in such cases and just do a sterilization without informing them. But again, that is illegal. So that is the only reason why you cannot do it. So,
so that
you can
is
tell the patient's husband that, look, she will die if you don't do a cesarean. The patient will then quietly come back and tell you that don't do this because he will just marry a second again. He will abandon me.
So anyway, she will not be alive for third
Exactly,
session.
ma'am.
Anyway,
Exactly.
nice.
So, yeah.
Nice
So, ma'am,
cases, Aditya. Yes, you proceed.
So, yeah, ma'am, there's a question to our expert. So, ma'am, please elaborate on the cardiovascular changes in pregnancy. So, basically, what we want is physiological effects of pregnancy on the cardiovascular system. So, that is how we will manage these cases.
Kasturi has not joined.
Okay.
So there will be a fall in the vascular resistance. Systemic vascular resistance will fall. There will be an increase in the cardiac output to almost 30 to 50%, which will be peaking at 24 to 28 weeks. And there will also be an increase in the heart rate 10 to 20 weeks. And there will be a fall in the peripheral resistance, and there will be a fall in the diastolic as well as the systolic BP.
Correct, ma'am. Correct.
There will also be an increase in the renal plasma flow, so there will be increased GFR.
Yeah.
So normally there will be a bit fall in the urea and creatinine levels.
So the most important is, ma'am, because of systemic vasodilation, you will get reduction in systemic vascular resistance. So in cardiac diseases, depending upon what the disease is, these changes may be either exaggerated or they may not happen. So the pregnancy may be poorly tolerated. So, ma'am, the next question, in a case of mitral stenosis, what is the commonest cause of mitral stenosis?
Rheumatic heart disease. That is the commonest.
Correct, ma'am. And particularly rheumatic heart disease cases are usually mild and they may remain undiagnosed in pregnancy. So the problem is we might be the first doctors to kind of see this patient as far as her cardiovascular status is concerned. That is the only reason why obstetricians need to have a stethoscope occasionally.
Yes.
And then second question, what is the definition of a severe MS, ma'am?
So when the valve area is less than 1.5 centimeters squared, we call it a severe mitral stenosis. And even it might be less than 1 centimeter, they will develop heart failure. Even if they're asymptomatic before pregnancy, they are more likely to develop heart failure during pregnancy.
Correct, ma'am. And ma'am, heart failure typically occurs during second trimester. Usually first trimester is a good time for these patients. This is when the cardiac output peaks, or it may happen postpartum occasionally. Yes. And third question is, ma'am, what are the complications of mitral stenosis in pregnancy other than heart failure?
The patient can go in for
atrial fibrillation can occur.
I think ma'am has already elaborated on atrial fibrillation, and the other thing is pulmonary edema and tachycardia. Yeah, and it is important to remember that pulmonary hypertension may also occur, which may result in a right ventricular failure, not just left ventricular failure. Mm-hmm. So then how do we manage mitral stenosis, ma'am? Pre-pregnancy?
Yeah. Shobana, anyone can take this.
Pre-pregnancy, yes, pre-conception counseling is very must in cases of patient who had prior heart disease. Recently, we are emphasizing on doing, actually in previous years when we are doing post-graduation, routine echo was not done for all obstetric patients. Nowadays, as per NHM guidelines, they are emphasizing on doing routine echocardiography at least once during pregnancy. Oh, and today recent guidelines, guidelines, yes, ma'am. Now in recent guidelines, they are saying that yes, ma'am. Now they say that we have to do twice, once at the booking visit and once in the third trimester. Now, yes, ma'am. Now they are advising that. So it's very important that preconceptually we do. If we know that they are having a heart disease, preconceptual counseling is very must. And if a patient is having severe mitral stenosis, it is best that we offer surgery prior to conception. And in certain cases, it is better they avoid pregnancies. Yes.
Aditya, do you do that routine echo for all antenatal patients?
No, ma'am. Ma'am, it is not accepted in my part of. I think we in North are well behind you people from South. The kind of patient's awareness is very, very minimal here, ma'am. So honestly speaking, if I tell a patient go and see a cardiologist and get an echo done on a routine patient, they will look at me like, "Hame kaun sa heart defect hai?" Okay, I am not a sick person. I'm just pregnant. So, ma'am, it is very difficult. But yeah, hats off to you if you kind of manage. If you are managing to get all your patients to get an echo, that too twice, ma'am, that is perfect. I mean, that
everything is done out of
ideal scenario.
Everything is done freely.
Government rule only once. But Sri Kritika is telling twice. That depends on the hospital.
No, ma'am. Today they have released the guidelines and they have emphasized and they have sent to all the government institutions that we should definitely do echo twice, ma'am.
Twice and 10 weeks once, and then the third trimester.
That's brilliant, ma'am. Because but the question is, ma'am, if you are only allowed one echo in pregnancy, when would you want to do it? Would you want to do it at 10 weeks or 35 weeks?
After 24 weeks, sir.
We do it at 20 weeks.
As per here, Justin Paul is the cardiologist who is involved with this cardio-obstetric registry. So he will advise at 20 weeks. But now, as she told, at the first visit and again at 20. If anything symptoms become severe means, then we can do it as of needed.
Ma'am, do you not want to defer the echo for 30, 34 weeks? Because then you'll pick up a lot of peripartum cardiomyopathies as well. Rather than doing it at 20 weeks, if you've done it at 12 weeks, then ideally what you should be doing, in at least in my opinion as an obstetrician, is to defer it for 32 to 35 weeks time.
But the advantage of doing echo in first trimester is to pick up any undiagnosed cases of valvular heart diseases. That is one advantage. So we catch them early.
First trimester, I completely agree. Yes, in an ideal world, if
yes, we can repeat. I think instead of telling only one echo in third trimester, let the first echo be in first trimester universally, and maybe depending on the risk factors, and if we have the facility, yes, do again in third trimester.
Yes, sir. If done very late, we may miss out certain things and may lose patients, sir.
Yes,
correct.
Yeah, practically in our place, we never initially we used to do it only when there is tachycardia, unexplained tachycardia, and if they have dyspnea. In the beginning, in 2017, then later we diagnosed 2 or 3 cases, pulmonary stenosis, mitral stenosis once at 28 weeks. With a murmur clinician actually. Then we referred, then we thought we'll better. It is a ESI hospital, so we have referral facility. So we started doing it regularly at around 5 months, 20 weeks after the anomaly scan or during the anomaly scan. So now we have a cardiologist, so we do twice. And it is good actually. We pick up the
Here,
cases.
madam, for all preeclampsia cases or hypertensive disorders, we are doing again in third trimester in case.
Yes, more obesity and preeclampsia.
Yes.
Okay, ma'am. So the next question was, ma'am, what drugs and treatments would you advise these patients in pregnancy, ma'am?
So beta blockers to slow the heart rate, because we should keep down the heart rate. That is the most important management here. And also anti-failure measures, low doses of diuretic may be considered, and anticoagulation, as we discussed earlier, to prevent thromboembolism. And yes, especially left atrial thrombosis. And if they large left atrium on echo, more than 60 ml per meter squared, or if the heart failure arises, but best to give the anticoagulation.
Right.
Ma'am, no, ma'am, don't you use penicillin, ma'am? Do you, ma'am?
Penicillin prophylaxis in the, I think during the pregnancy, we have other cefotaxime and other stuff nowadays, broad spectrum antibiotics. So we don't usually, we stopped using penicillin because some of them are allergic to it. So we don't use it here.
Because our cardiologists, they routinely put them on oral penicillin, and we give them bisoprolol, and we give them Lasix also.
Yes.
Right. Ma'am, the next question is, how frequently would you monitor these patients in pregnancy, and how would you monitor them?
Every month, I think best to do a echo every month and visit the cardiologist, especially if moderate and severe. The cardiologist better for them to come and visit her, especially after 20 weeks. Usually in those days, we used to get regularly mitral stenosis patients around 2000, when we were doing MBBS, we used to have, so we usually admit them at 20 weeks because there are 24 weeks, they might start, the disease might start worsening. And also after delivery, they will have during or after delivery, they will develop failure. So those we used to actually get the opinion of the cardiologist every month. These days, we regularly ask them to see a cardiologist, and every month. And other things like IUGR, we have to monitor the baby as well with look for IUGR. Usually these women with heart disease, the babies are small compared to others. So because of the less cardiac output, I think. So we have to monitor the baby as well and the mother. And see, yeah, that's it.
I would like to add on one point, madam. Like it depends upon her NIHA classification. Probably if she's NIHA 1 and 2 and her condition is bit stable, we can have, of course, a frequent visit, like monthly one regular checkup should come and she shouldn't go away from the follow-up. And if she falls under NIHA 3 and 4 and the further repeated visits has to be there and it should be a multidisciplinary team. And she should be admitted earlier in an obstetrical HTU and if required an ICU as well, ma'am. And it depends upon like how we going to terminate her and the further post-operative monitoring. If she is anything in NIH 9 3 and 4, we're going to plan her for a cesarean. Definitely she should be in ICU for a longer time to monitor her fluid and early starting of fluid oral fluids. And also contraceptive, as madam was told, definitely a contraception has to be the thought has to be there for us. We have the sterilization if she falls under 3 and 4 and she chooses the previous paraglidite as well.
Nice.
Infective endocarditis also prophylaxis should be given, isn't it?
Yes, ma'am.
Yeah.
We do give. Like she told, we ask them to come once in a fortnight, and the frequency of echo may differ depending upon the cardiologist. But as she told, NIHA 1 and 2 has to come once in 15 days. And if it is NIHA 3 and 4, definitely they're going to admit them.
Yes, Aditya.
Right, ma'am. So I think this is the last question. So how would you manage the delivery of these patients, ma'am?
Udayashree, you can take up the question, I think.
Yes, madam. If patient is NYHA class 1 or 2, yes, she can be candidate for vaginal delivery. But what you have to keep in mind is that proper position, good labor analgesia, oxygen, avoid fluid overload, encourage plenty of oral liquids rather than depending on IV fluids. If augmentation is required, keep the oxytocin drip on a drier side by using higher concentration of oxytocin. Avoid drugs which can cause tachycardia, like anticholinergic drugs and others. Yes, IE prophylaxis should be given in second stage. And prophylactic instrumental delivery, preferably forceps delivery to cut short the second stage. Be careful and avoid giving methergine either for ATMSL or for treatment of PPH. Yes, keep always blood ready, PRBC ready, and give Lasix in second stage and also again postpartum to decrease the effect of increased preload. I think with these things, we should be able to manage the low risk, that is NYHA 1 and 2. Yes, 3 and 4, they may not be fit for normal delivery. So planned elective cesarean section with the expert team will be ideal. And yes, thromboprophylaxis should be given postpartum.
Postpartum. And when would you start that, ma'am?
Sir, it depends on whether she is having a valve, what kind of valve and all. So patients other than having mechanical valves, you can start 12 hours after the delivery, sir. If they are having mechanical valves, you want to do it earlier, maybe 6 hours after the delivery of cesarean, because high risk of thromboembolism is there. And high risk patients will continue for 6 weeks. Whereas for prophylaxis, if we are giving, 10 days at least should be given.
Ma'am, the RCMP guidelines.
Yes, sir. 6 hours after the vaginal delivery and 12 hours after the cesarean section.
So, ma'am, it is 12 hours after you give the spinal or remove the epidural catheter. So, if you have inserted the epidural catheter and you are going to leave it in place for, say, a couple of days for analgesia, then you can give them 1 dose of low molecular weight heparin in between. It is not to be given 12 hours at the before removal. So you need to delay the removal.
And
of
also 4 hours after removal also we should not give.
Yeah.
That is a window period.
Yeah, correct. Right, ma'am. So,
and one more point, sir, if we are doing a cesarean, we should insist on the IV fluid infusion rate. Like it has not to be a routine 100 ml. It should be 50 to 75 ml per hour. Strict input-output monitoring. And you should encourage to start oral fluids as early as possible. And restriction of IV fluids will help out much in this case to prevent pulmonary edema.
Correct, ma'am. So the principle is basically that we want to keep them on the dry side rather than on the wet side to prevent accumulation of fluid in their body. And one of the commonest areas where we can see fluid accumulation in our obstetric patients is in lungs. So pulmonary edema is a very common complication, and not just in cardiac disease, but also in preeclampsia and a lot of other diseases. Ma'am, any expert comments, ma'am, from our experts
Yes, Aditya.
about
Everything,
any
all
principles?
panelists are experts. They are discuss fantastic. All are experts. So fantastic cases you have taken,
Yeah.
Aditya. Good discussion.
Thank you, ma'am.
Anyway,
Thank you so
nice
much.
of you. But we missed you
Thank
for
you,
the
ma'am.
first two cases.
I know, ma'am.
We had a
I'm really
wonderful
sorry, ma'am.
discussion.
I'm really sorry, ma'am.
No problem,
One of
no
the
problem.
cesareans bled.
Emergency is
So she
important.
just couldn't stop bleeding, ma'am.
Okay, no problem. Thank you. I think with this we are ending. Yes, I thank all the society presidents and secretaries and Dr. Vijay for the wonderful talk and Dr. Aditya for wonderful moderation and panelist. What to tell, I don't know. Dr. Karpahambal, Dr. Sri Pritika, Shobhana, Uday Sri, some Radhika and Dr. Prachi. Full discussions. It will be available in the YouTube also. You can show to your colleagues. Thank you, Dr. Aditya, and the moderator, Dr. Radhika and Dr. Madhumita. Thank you so much for this webinar. Thank you, Dr.
Thank you,
Aditya.
madam.
Thank
Thank
you
you
so
for
much,
the
ma'am.
opportunity.
Thank you so much,
Can
ma'am.
we all
Thank you for
have
the
a pitch, madam,
Thank
with
you.
all the faculty in the same screen?
One just
Thank
last
you.
one patient where we had no. I just want to just share this, this atrial fibrillation. Can you see the? Can you see, madam? The
Yes,
atrial.
ma'am, we can see, ma'am.
This is the atrial fibrillation she had. And next slide. This is after IV digoxin.
Oh,
This is a case of
Fantastic.
recent valve where she had a radio frequency ablation of the for a supraventricular tachycardia. In spite of that, this is a CT ECG. The heart rate of 180 to 200. She came. We had to admit her at least 3-4 times to give her IV digoxin, and this was a post-digoxin ECG. I just wanted to share the ECG pictures.
Nice.
Thank you.
Very nice,
All the
madam.
faculties,
Looking at
please
the
open the
ECG only, we are
video. We
feeling
will have a
happy.
photo. Uday Sri wanted for NAC. All the faculties, please open the video. Sahiti, take a photo.
Okay, ma'am.
Sampath ma'am, those days in KGH, we used to get a lot of mitral stenosis and these
Yes,
rheumatoid.
but now it has reduced.
Reduced,
Anyway,
yes, ma'am.
photo
Yes, ma'am.
taken.
Taken, ma'am.
Yes, put it in the group. Thank you.
Thank you.
All
Thank
of
you
you,
so much,
thank you for
madam.
the nice discussion.
Thank you, ma'am. Thank you so much.
Thank you,
Thank you
Aditya.
for the opportunity.
And
Thank you,
Uday
sir.
Sri.
Aditya, sir.
Thank you. Thank you.